Good morning and good afternoon to those joining us today. Miyuyam Natong Alakalak Yaka no Nathaf Pamangai. My name is Alec Halak. I'm a member of the Pama Band of Luiseño Indians, and I have the honor of introducing and presenting this month's Health Justice Seminar Series of the Lancet Commission on U.S. Public Policy and Health. This session is titled Native American Health Inequities, and this webinar is being recorded, so please keep that in mind. This series intends to bring together experts and activists in order to share ideas and formulate possible solutions to long-lasting inequities and understand how these issues have impacted health across the life course. I will be introducing each of our panelists and ask that you follow along, and throughout this webinar, please feel free to share on social media and take not what you hear, but what you learn. First, and I ask each of the panelists to join me on camera as I introduce them, we'll be hearing from Michael Bird. Michael has over 25 years of public health experience in the areas of medical social work, healthcare administration, and public health policy. He's the first and only American Indian president of the American Public Health Association, having served from 2000 to 2001. After Michael, we'll hear from Dr. Jacob Bohr. He is an associate professor in the departments of global health and epidemiology at Boston University School of Public Health. His research applies the analytical tools of economics and data science to the study of population health. After Dr. Bohr, we'll hear from Dr. Teresa Montoya. She is a social scientist whose research and media production focuses on contemporary problems of sovereignty and toxic contamination in relation to historical legacies of land dispossession and resource extraction across the indigenous Southwest. And finally, we'll hear from Dr. Mark Emerson, who is an assistant professor in the Department of Epidemiology at the Gillings School of Global Public Health at the University of North Carolina at Chapel Hill. His research focuses on integrating biological and socioecological perspectives and addressing cancer care disparities and access to care. This session is gratefully co-sponsored by the UCLA Research Theme in Health Equity and Translational Social Science, the Rangel Social Medicine Grand Round Series, the Roosevelt House Public Policy Institute at Hunter College, the Cambridge Health Justice Lab, and of course, the Lancet. Throughout the course of this seminar series, I hope that you will learn really the key determinants of American Indian and Alaska Native health in the United States, and understand that it is much more than individual failings or individual behaviors that affect the health of the population, but really long-standing structural failures that have really shaped the disparities that we see today across the last 5 centuries. Without further ado, and to stay on track, we are going to now start and introduce Michael Bird. Please take it away.
Thank you, Alec. Good morning and greetings from New Mexico, home of the Pueblo Revolt of 1680, one of the most successful rebellions in the Americas, at which point the Pueblo, along with supporting tribes, drove the Spanish out of New Mexico for 12 years. They've come back, but things have turned. I'm going to cover basically 3 points, and I think that are critical to really understanding and working with indigenous communities, Native communities. And first of all, I'd like to start out with a quote from Richard Nixon, President Richard Nixon, in his special message to the Congress on Indian Affairs on July 8th in 1970. And he said, "To the Congress of the United States, the first Americans, the Indians are the most deprived and most isolated minority group in our nation. On virtually every scale of measurement, employment, income, education, health, the condition of Indian people ranks at the bottom. This condition is the heritage of centuries of injustice." It's really important to understand the historical and cultural context. While there's much discussion about social determinants of health, structural determinants of health, political determinants of health, I think one point that needs to emphasize is the historical aspect. While American Indians are defined as an ethnic population, we possess a unique legal government-to-government relationship via treaties and executive orders. We have legal status with federal, state, and our own tribal governments. The federal government recognizes 574 tribes in the contiguous 48 states and Alaska. And in order to really have a truly enlightened conversation and discussion addressing Native American health inequities, one must have some knowledge of the historic and legal context. Any discussion must address the underlying conditions that have confronted American Indians for over 500 years. In that vein, I'd like to recommend two documents for your consideration. The first is Exterminate All the Brutes, a film produced by Raul Peck and an HBO documentary. It is a historical and global discussion on racism and addresses the true historical experience for many communities of color. The second is a most recent publication titled Not a Nation of Immigrants, Settler Colonialism, White Supremacy, and a History of Erasure and Exclusion. And this was written by Roxanne Dunbar Ortiz, Beacon Press. When you're talking about Native communities and pre-existing conditions, it is widely noted that of any racial or ethnic group, American Indians and Alaska Native have the highest mortality and morbidity rates of any population in the nation to date. They also have the shortest life expectancy. American Indians also are killed at a higher rate than any other racial or ethnic minority in police encounters. This is all research conducted by CDC. As it relates to COVID, American Indians have had the highest COVID rates of any community. And American Indians and Alaska Natives are 3.5 times more likely to be infected with COVID than whites and 1.8 times more likely to die. Nationwide, 1 in every 475 American Indians has died from COVID compared to 1 in 645 African Americans. American Indians, Alaska Native also have had the best vaccination rates for the first vaccine dose when COVID vaccinations began in 2021. So there's an interesting contradiction, but an interesting and something worth studying as to why Native communities have responded in such an affirmative, positive way, protecting their people. As it relates to the Navajo Nation, there were 39,000 cases of COVID at the onset of the pandemic, according to tribal data. In May of 2020, there were 2,304 cases per 100,000 people, the highest infection rate in the nation. Interestingly enough, the Navajo Nation boasts a 72% primary vaccination rate among residents, higher than the national rate of 62%. I'll close now by just making the case and the point again that if one is going to really address the issues that impact Native communities, there has to be a thorough understanding of a historical experience that Native people have had and what has created the conditions that make us, that create conditions which we have the highest mortality and morbidity rates pre-COVID and highest COVID rates as it relates to the COVID experience. Thank you very much. Appreciate your time.
Thank you so much, Michael. As you poignantly pointed out, to present disparities without context really causes harm to our peoples, and to really get at the core ideologies of these disparities is so important in public health and policy. Next, we'll hear from Dr. Jacob Bohr.
Thanks so much, Alec. So I'm speaking from Roxbury, Boston, Massachusetts, which is the unceded territory of the Massachusetts tribe. On the left shows the map of the historical villages of the Massachusetts Nation. It's interesting to start here locally because a lot of the themes of genocide, displacement, and forced assimilation that occurred throughout the United States first occurred in the first contact areas in New England. In Boston, up until 2005, there was actually a law on the books that prohibited any Indian from entering the city, and this was only repealed under 20 years ago. In Roxbury, Roxbury is the site of Reverend John Eliot's church, and what you see on the right is the Bible that he had translated into Massachusetts language as part of the attempt to convert Native peoples to Christianity, which was basically if you weren't killed or pushed off the land, then that was the third option, was conversion and moving to one of the praying towns in Massachusetts. So these themes of erasure and these mechanisms of erasure structure what I'll call sort of an invisibility paradox in Native American health. So on the one hand, these policies of erasure have had profound negative impacts on population health of Indigenous peoples here. But at the same time, the policies of erasure have also hindered access to data needed to assess patterns in population health, and thus have rendered invisible some of the most important trends in population health amongst Native Americans. The US Census has counted American Indians since 1890. This was the first time that the US actually went out and attempted to enumerate American Indians living in Indian territory or on Indian reservations. On the left is the 2010 census form, where American Indian or Alaska Native is one of the boxes that we have the option to check on the census. What does it mean to be American Indian or Alaska Native? Aggie Yellowhorse, in a recent article, has a nice discussion of the sort of complexities of racial identity amongst American Indian Alaska Natives, saying that this is actually AIAN for short. It's not so much a racial identity, but a political one, as Michael mentioned, and yet still it's meaningful to track patterns in population health amongst American Indians and Alaska Natives, because despite tremendous diversity across nations, there are shared experiences of genocide, dispossession, removal, forced assimilation, and structural racism. And for these reasons, it's very important to have accurate data that allow us to actually quantify current disparities and consequences of these structural factors. Keeping with the census denominators, American Indians and Alaska Natives are a fast-growing share of the U.S. population. So from this plot shows in blue the percent of the U.S. population that identifies as American Indian Alaska Native, and in red with the hollow dots the total population of that group. From 1890 through 1950, there was a stagnant total population and a declining share of the US population constituted by American Indian and Alaska Natives. From 1960 to 1990, however, there was a very rapid and large increase in the share of US residents identifying as AIAN, coinciding with the end of forced assimilation as federal policy. And by 2020, AIN make up the largest proportion of the US population at any time in the last century. And today, the American Indian Alaska Native population is literally 10 times what it was in 1950. So not only are American Indians still here, but this is a population that is growing and has grown tremendously in the last half century. What is this growth about? Not all of this is fertility or natural increase. A lot of this is efforts to end the erasure of these populations in government statistics. A report in 1996 by C. Matthew Snip showed that in the 70s, there was a tremendous increase in the proportion of people who were identifying as AIAN. And we did a reanalysis of these data, looking at census data through 2020, looking at birth cohorts and showing that actually the size of these birth cohorts identifying as AIAN was increasing over time, which isn't really possible without people switching their racial identification between censuses. When does this happen? It happens in the midst of an awakening around American Indian rights, including with the American Indian movement. And interestingly, we've seen in the last 10 years a further increase, particularly amongst younger people, in identification as American Indian Alaskan Natives, which I'll note coincides with additional activism around American Indian rights. Although American Indians are increasingly identified within the census, within the population statistics, their mortality statistics and health statistics are often dramatically underrepresented. So a phenomenon that's been noted for decades is the misclassification of race and ethnicity on death certificates. This is a report from Elizabeth Arias and colleagues from just last year, which did a linkage and found that 25% of AIN deaths are uncounted when looking at race on death certificates. In collaboration with Michael, with Elizabeth Arias, David and Steffi, John Hakes, and support from the Commonwealth Fund, we've undertaken a project to have our own effort and try to get more precise and more accurate estimates of mortality rates amongst American Indian and Alaskan Native populations. And we're doing this by using a data source called Mortality Disparities in American Communities, through which the US Census linked the 2008 American Community Survey to over a decade of vital statistics death records. And these are linked by Social Security numbers, so it's a very rigorous linkage. And it enables comparisons of self-reported race ethnicity with death certificate race ethnicity for a representative sample of people and deaths during this period. It enables longitudinal analysis of mortality by self-reported race and assessment of mediators of the impact of structural racism on mortality disparities. So I'll show you a few preliminary results. So this plot shows this plot shows the percent of deaths that are assigned to each racial ethnic group on a death certificate, where each row here is the population that self-identifies as each race. So just focus on the top line here. Amongst the people in the 2008 American Community Survey who identified as non-Hispanic American Indian Alaskan Native, amongst those who died in the subsequent 8 years, 40.5% of those deaths were assigned to non-Hispanic American Indian Alaskan Natives on the death certificate. So almost 60% were misclassified. And although there's some white, Black, Asian Pacific Islander, and Hispanic people who were misclassified as American Indian Alaskan Native on their death certificates, using death certificate IAN identification results in a 48.5% undercount of American Indian Alaskan Native mortality. This plot shows deaths per 100,000 based on race as reported in death certificates and compares it to race based on self-reported AIAN from the American Community Survey. As you can see, across age groups, death rates are underreported by about 50%. Why does this matter? Well, there's already a lot of attention appropriately on the large health disparities and major health crises facing Indigenous people in the United States. This is a sample of articles. I'm excited to hear from Mark and Teresa in a moment. But there are the existing measured health gaps, even before we correct them, are already very large. At younger ages, Native Americans have age-specific mortality rates that are 8 times the age-specific mortality rates of other wealthy nations, which we used as a comparator in this analysis. As Michael mentioned, in the last couple of years, there's been a 6.6-year decline in life expectancy amongst American Indian, Alaskan Native populations during the pandemic. This decline was not just due to COVID, but it was also due to so-called deaths of despair, including drug, alcohol, and suicide mortality, which where there were huge longstanding disparities, but also huge disparities in the increase from 2019 to 2020 and again to 2021. Due to misclassification, these are all substantial underestimates of the true mortality burden amongst American Indian and Alaskan Native people, and our future work with the Mapping Mortality Disparities in American Communities project will attempt to quantify and correct for these biases. Thanks very much.
Thank you so much, Dr. Bohr. This erasure has really been described as the modern form of racism against Indigenous peoples. And even when Indigenous entities seek access to their data, they're often told, it's not collected or they're denied access to it. So to understand the data is to really understand one piece of a much larger issue. So thank you. And next we move on to Dr. Teresa Montoya. Welcome.
Thank you so much, Alec. Well, I, as the lone social scientist anthropologist in this group, I'm going to give a little bit of a background of my research and actually how that has led me to more of an interest in public health. So this image here was taken by the Associated Press in 1979, and this is near the Rio Puerco, a site of the worst radioactive spill in US history. It's called the Church Rock Uranium Mill Tailings Spill, and it's located in checkerboard lands in the Navajo Nation of New Mexico. There's a sign here, it's warning people to stay away from the river. Tests were conducted, but by and large, Diné citizens in the communities adjacent to this spill site were not aware of the impacts environmentally or to their health stemming from this spill. Fast forward to 2016, which is when I was living back home on the Navajo Nation to do my field work. And I was following the discharge of another spill, which was the Gold King mine spill from August of 2015. That spill was a hard rock mining spill near Silverton, Colorado. And although it wasn't radioactive, it had a lot of hard metals associated from mining from the past century. And that spill went directly through the heart of the Navajo Nation in the San Juan River. The picture here is at a Department of Energy managed site near Shiprock. And Shiprock was also at the site of uranium extraction. So this is a former mill tailing site. So by and large, the Navajo Nation and the broader Colorado Plateau has been site to extensive resource extraction over the past century. So the two images that I just showed you, the black and white photo, which was taken at the Church Rock spill source point outside of Gallup, New Mexico, and then this color photo I just showed you outside of Shiprock, it's just part of a broader complex of energy extraction. And for reference, my family lives in Windrock, Arizona, which is the capital of the Navajo Nation, and where I conducted my research was in Sanders community, which is where my maternal grandfather was from. So that is downstream from the Church Rock spill source point. And till this day, they are still dealing with the consequences of water contamination in their community. There are over 500 abandoned uranium mines across the Navajo Nation. So this EPA map just shows with each of these red dots, the extent to which mining was practiced on our homelands. This is just a picture of Sanders today, and in the foreground you also see a frac sand plant. There's multiple regimes of extraction that are still continuing in our broader borderland region. And also, I'd be remiss if I also didn't mention, the aftermath of Nevada test site. So this gives, an image of what is called the downwind region. Although politically, even though in the prior image you could see the extent to which there was radioactive contamination from the spill site or the Nevada test site, the green and blue areas are the only regions that are covered by what is called RECA, which is the Radiation Exposure Compensation Act. So this is just another example of the multiple exposure pathways to which Dene citizens have been exposed to over the past century, not only through ingestion of contaminated water, but also of radioactive particles from this site. This is just an image of many. This is a water, a livestock water tank near Dene Hotso, Arizona, on the Navajo Nation. And what's important about this is that over 30% of households on the Navajo Nation do not have running water. And so that means many households will rely on hauling water, often from unregulated water sources, such as this livestock tank. So that not only for watering their livestock, sheep and cattle, but also for household use. Oh, it's not turning, sorry. And I love sharing this image, which is from the Radiation Monitoring Project, which was a grassroots group that I worked with back in 2015 and 16. And this image, artfully shows like the bioaccumulation of different forms of uranium contamination. So bioaccumulation in the bones and the liver, but it also points to other radioactive minerals that are present on the Colorado Plateau. So now shifting gears, my broader research, which was interested on the aftermath of all of these forms of extractive industry, and really the limitations that the Navajo Nation has been able to exercise in terms of its sovereignty and jurisdiction to remediate some of these environmental problems, is also a problem of public health. So this here is a map showing the various Indian Health Service regions across the Navajo Nation. And I also just wanted to point out, this is a list of all of the different IHS facilities across the Navajo Nation. And also I'll point out here, there's a number, 5 of them, they're listed as Tribal 638 facilities. And so that means that these facilities have contracted to be able to be run by the Navajo Nation itself rather than the IHS. And so I think, this is a point in terms of, the exertion of sovereignty of not being able to rely, exclusively on the inadequate federal, IHS facilities, but being able to practice more community-centered care. So the only main hospital on the Navajo Nation that's run through this program is the Fort Defiance Indian Hospital. And I'll just point very quickly to this article that I was able to co-author with Mark Emerson, who will be speaking after me. And this was, at the time of this writing, this was before, vaccinations had become publicly available. They were still developing them. And we had a lot of conversations, as we were both, quarantining from our respective places. Currently I'm in Chicago, which is where I work. But this was very difficult to be away from family back home on the Navajo Nation, and likewise for Mark, who is in North Carolina. And as someone who's trained in social science, I was also really interested to better understand Dene responses to disease, not just contemporarily, but also historically. This is also just a sign that I took a picture of on the Navajo Nation, which basically says, please stay home. And a lot of folks put these signs up, which I think is just an indication of a different sort of ethic of care and community. And And to end, I will leave with this quote, which was not about COVID, but actually about the Spanish flu from a century prior. And so this is, what we go into in our article. And, just briefly, I wanted to point to the fact that even back then, the lack of access that Dene people had to Western medicine was, seen as, impediment to their health, and oftentimes overlooking the forms of community-centered health and care and quarantine that many Dene were already practicing on their own. So therefore, our current analyses of COVID-19, shouldn't fall into this common trap of deficit narratives and treating Western medicine as the only way to approach disease such as COVID-19. So we need to also consider other frameworks of care, indigenous frameworks of health. And with that, I will leave it to my colleague, Mark. Thank you.
Thank you so much, Dr. Montoya. It's very clear from your presentation that this legacy of environmental contamination really sits with us today, but will have multi-generational effects for decades to come. And now, last but not least, Dr. Mark Emerson, who I have known for quite some time.
Okay, y'all, I hope, just bear with me for 1 second. You would think at this point, I'm on a different setup at home, but I'm trying to figure out my shared screen here. Give me 1 second here. I'm doing like a backup idea here. I just not my typical setup here, so just bear with me. Okay, I hope this works. I'm just going to do it from.
It looks great, Mark.
Here. Okay, great. Thanks for the affirmation here. Okay, so, and also, is my video working or? Okay, well, I'll just go ahead and get started here. So, yeah, I just want to share my appreciation, and I'm really honored to be here and share the space with y'all. And also kind of based on all of the things that have been leading up to this point, and thinking about the historical underpinnings and hearing from Michael, and especially, I think, is really critical. And so mainly in that same line here, what I'm sharing is something along the same narrative here. This was taken from the New York Times about a month ago. And so we can see here, even with the effect of COVID here, just the drop off for everybody really, but we can see this effect most strongly with natives from the time period of 2019, 2020 here, and this drop off of life expectancy. What really fits in the context of like, what are all these underpinnings that are going into these disparities that we're seeing now? And so I want to share a little bit about my research and kind of the context and reason for the research as well, and thinking about how we're carving out or indigenizing, or these buzzwords of decolonizing research methodology, and how it's this union, not this language of either or, but how we can sort of blend these things together. So in my talk, I hope just to briefly touch on this and also give a context of why. Before I do that, I just want to quickly recognize and acknowledge the land and sovereignty of Natives and Indigenous nations here. So where I'm tuning in from is from Orange County, Durham County. So these house the Duke University and University of North Carolina and Chapel Hill. These are the traditional lands of the Occaneechi, the Eno, Saponi, and Tuolani peoples. So these are unceded territories of that have had a violently displaced through the colonization of North Carolina, that have had generations of kinship systems in this area, which are alive and well today with Lumbee, Eastern Band of Cherokee, and the Saponi nations. And so I also want to just, okay, here we go. Give a context of thinking about this. So I recently went to a talk, and I like this quote. One of the reasons people do land acknowledge statements to remind us that our stories are not the first stories to unfold in the space that we occupy, and think about the ways that we walk amongst not just the memories of people, but also acknowledging the people of the government's work to displace. In doing so, we bring a sense of seeing, saying, knowing, and reckoning. And I highlight these words because I often think about how we frame research and how we think about research and how we're trying to be mindful of research. I feel like these action words here, these verbs, are really important in thinking about how we're thinking about the research work we're doing, and also being mindful of the land as well in these land acknowledgements. And in the theme or effort of really trying to bring my whole self and into the work that I'm doing, and thinking about our identity and the meaningful representations as what they mean politically and academically and geopolitically and socially constructed shades of identity. I think it's important here. I just want to acknowledge my father and share a little bit how the work that I do in cancer space has impacted me personally. So when I was in my PhD program, my father was diagnosed with a late stage stomach cancer. And so as an only child, I moved back home to the res, to the Navajo Nation, to be his caregiver until he passed from the disease. And so my dad, I think, was really important. What I want to share was really what I valued about his mentorship, in this way that he really reaffirmed my identity, but also kind of this union, right? This and language of reminded me to remain competitive in this modern Western context of academia, while really reaffirming my identity when I returned home. And that was meaningful in this context of fully understanding the context of Native identity and the value of academic research. And so altogether, losing my dad to cancer has really fueled my passion and commitment to thinking about how we can integrate cancer research in ways that are meaningful for Native research. So here's a map of North Carolina. As you can see, it's almost, it's a large land area, 54,000 square miles, and just superimposed roughly to scale is the Navajo Nation, just to give you roughly an idea of how big the Navajo Nation is. And then here's on the left a slide of some of our facilities, right? So the Navajo Nation only has 13 grocery stores, and thinking about how big that land area is. And again, thinking about how we tie in all these social determinants of health, access to healthy foods is a major issue. And then in the stars there are our Indian Health Service units or hospitals, which are 8 currently serving that large area of the Navajo Nation. And then the right here is one, again, share an example from my dad. So this map that I created with these pins are border towns of the Navajo Nation where cancer care exists. And so this map that I drew here is the journey of over 200 miles or 3.5-hour drive that I would have to take my dad to have his cancer treatments provided, the consultations and surgeries and so forth. So these are just to give you a context of a lot of the barriers, I think, that are specific in terms of tribal remoteness of lands, infrastructure. Internet was a big part in COVID in terms of learning and education, but also in terms of telemedicine and the challenges there. Paved roads for my dad specifically, with the stomach cancer, just any little bump in the road really aggravated, I think, on that and reduces quality of life towards the end. Transportation, as shown here, the time and financial costs to access cancer care, et cetera, have really in the light, and as has been exacerbated in these disparities as well when we think about the pandemic as well. And so the next just few minutes here, I'm going to kind of blaze through some slides here, but I just want to give you a flavor, not necessarily to go into detail here, but just really think about this in a zoomed out overview kind of viewpoint. And here we're just looking at this more multidimensional, multi-framework of how we can think about health, both at the individual level, family level, the community level, the hospital level factors, right? All these areas that we can make impact and change. And here again, the idea is that we can adapt these models here as we have been doing. And so Spiro Manson is Chippewa. And so this is an example of how we're thinking about spirituality, collective resilience, historical trauma. And as epidemiologists, I think a lot of our job is really thinking about what we are measuring, how meaningful that is that we're measuring, what do we know, how well are we measuring it, and also what are we not measuring, and how well are we not measuring it, or what do we know about that mismeasurement? And so when we're thinking about these things, I think a lot of these things that you see on the slide that are in bold here are specific, I think, when we talk about Native representation in research. And so thinking more specifically about cancer research, there's a lot going on. And here again, the idea is that when we think about cancer, this can go from a cell to society. And so this is how we're trying to think about and frame our modeling here, and thinking about social environments, thinking about built environments, thinking about physical activity, thinking about socioeconomic advantages and disadvantages of neighborhood level factors as well. And so I just want to give you an overview of how all of these have individual contributing components to lead to these health disparities that we're talking about, specific, having specific underpinnings and unique aspects that I think warrant attention, specifically when it comes to Native cancer equity. And a lot of my focus is in the space of Native women cancer health equity research. And so that is to say that it's also equally important to explain why this research is meaningful, right? And so really grounding ourselves, I think, in a lot of and for me anyway, for Diné, it's really thinking about how we can capture these Diné ceremonial teachings and life philosophies that can provide a framework for living in harmony, beauty, and balance with our community and with also the natural world, which really fosters a sense of social responsibility, fulfillment, and cultural well-being that I think really can guide and orient, again, this union of thinking about how we carve out this research space specifically. And for me personally, how it relates to how I think about those that I work with and that I collaborate with, and those who are affected by our research. And so this provides a blueprint or a framework for how we can think about this. And so in the last remaining minute or two here, I just want to say that this blueprint is really guiding out this research that we're trying to create. And this research has to do with how do we improve access and treatment for Native women across the board. And so as we've heard, there's many unique aspects, including how we access healthcare. A lot of this for my tribe, for example, is treaty-based with the US federal government. And in these ways, you can see these as contracts. And in a lot of ways now, if we think about Native health, we can see these as breaches of contracts between these federal partnerships and at the tribal level of not fulfilling their duty to really think about this cultural well-being and health of Native people. And so this is creates some unique aspects when it comes to Native cancer health equity, both on tribal lands and off tribal lands, and off tribal lands, low rates of having private healthcare insurance or employer-based health insurance is part of the issue. And so briefly on the last minute or so, I just want to, I guess, give an overview of how we're trying to, we're talking about the context of the research, and then thinking about how we're doing this research is we're thinking about how we're modeling all of this. Again, going back to those models that are systemic, that are complicated, that have historical underpinnings, how we're measuring those and bringing those together methodologically. We're finding that across the board that these issues can compound when it comes to the area that I really focus on, which is accessing cancer care. And so these delays in treatment can really add up, and we're seeing these happen, especially in the light of COVID. And so I will wrap up now. I just want to show you that we've done some work in thinking about looking at this Native women cancer health equity space with breast cancer mortality, where we're seeing increased mortality for Native women. And that led us to think about treatment as well. And so for cancer treatment, what I want to end on here is just showing you that when it comes to accessing care and accessing treatment, compared to other race ethnicities, Native women have the second lowest initiation of cancer treatment. And then here, what I'm showing you in some of these last slides as I'm winding down here are that when we think about this study was done 5 years since they started treatment, the adhering to cancer treatments is the lowest among Native women compared to all other race ethnicities, as you can see here at 51%. And so what this means, I think, overall is that when we think about all these components together, this underutilization of healthcare is the greatest among Native women. And in these particular cases, when we look at urban Native women who might have greater access to care and have private healthcare insurance, in a way it represents a best case scenario, yet we still see substantial racial disparities. And so addressing these disparities specific for Native women is important. And again, really focusing on resilience and community strengths rather than when I go back to the community and hear from advisory boards, it's often like, we know what's wrong with us. We have the highest rates of things that are bad. We have low rates of things that are good. Like, how can we really think about community strengths and connections to care as important factors? And then just to end, that we've done some other work recently looking at this among cohort of Native childhood cancer care survivors. And really what we're trying to focus on here is we've done this between Black and white women in the South. We're really trying to focus on this handoff, right? A lot of this context that we're talking about today is policy. So on this research end, policy, where's the handoff? Like, how can we make this research important and meaningful, particularly for Native health equity? And a lot of this has to do with how can we think about interventions that have worked? How can we leverage that relationality as Natives to think about partnering with other underserved and BIPOC communities to really have interventions that have specific anti-racism underpinnings at these different levels, right? That I had mentioned, individual level, community level, hospital level, and how can these all play into ways that we've shown to here at UNC to be meaningful in a way that is representative of people in ways that specifically call out racism in how we see racial disparities across the board. And I'll end there. So thank you again for listening and for your time.
Thank you so much, Dr. Emerson. Now I'd like to ask all of our panelists to please turn on your camera. Mark, hopefully, and now you can join us now that you're not presenting. Just hearing you speak reminds me of the leadership of your father, and meeting him at so many SACTUS conferences was quite an inspiration to me as a college student. And hopefully, Michael, if you're with us, again, we have our Q&A feature, so please submit your questions. We'll give our first question to the individual who has been waiting about half an hour for an answer to their question. So perhaps I can pitch this to Jacob and Michael. Quote, what about the Native Hawaiian population? Are they included in the American Indian and Alaska Native numbers? So perhaps Jacob, if you could take the racial ethnic classification piece, and then Michael, perhaps touching on the sovereignty piece on this.
Yeah, so I can just tell you what's going on in the data that you presented. So Native Hawaiians are not included. They had been lumped in with Pacific Islanders in older census categories, and in more recent census categories, there's a Native Hawaiian and other Pacific Islander that is category that's separate from other Asians. But they have not been included in the AIAN category, at least in what we presented and what most other papers have presented. We have discussed doing some work to look at other to look at Native Hawaiians, to look at other populations indigenous to the rest of the Americas, Hispanic Native Americans, for example, in further work. But that's the short answer.
Alec, I've spent some time at the University of Hawaii and working with major Native Hawaiian organization called Papa'ololokai, who are part of the American Indian Caucus, American Indian Alaska Native Hawaiian Caucus of APHA, and their legal status clearly is different, but what parallels their experience, two things I'll mention. What parallels their experience is that many of the same health issues, social, economic, political issues are similar to our communities, Native communities, in terms of their being disenfranchised. And we think as Native people in the U.S. that we're treated in a manner that is invisible, and that fact, and the fact of the matter is that people don't know our experience, our historical experience, much less our present day experience. But for Native Hawaiians, it's even much more challenging because people just don't think about Hawaiians, don't view Hawaiians other than a tropical paradise. And there are many Native Hawaiians who were very active and have been speaking out on behalf of Native Hawaiians we basically the United States was basically again involved in overthrowing a sovereign government. They had their own queen, and we undermined and took what was theirs.
Thank you, Michael. Moving to Mark here. In your presentation, you referenced that over 70% of American Indians and Alaska Natives live in metropolitan areas, perhaps as a result of federal relocation policies and other factors. How are these individuals included in research studies? And if I could add on maybe a part 2 to that, how do you balance individual participation in research with community protections and the implications that it can have for sovereign American Indian nations?
Oh my gosh, yeah, there's so much in there. But starting with the last part, and forgive me, sometimes I like, as I'm trying to like think through this, it's like stumbling as I think out loud about this, but that last part is so key. Like that is like, I think where we're thinking about, when I think about the 5-year, 10-year trajectory of what like Native health equity can look like, I mean, a lot of that is shifting, you know, at least into more like mixed methody area, at least acknowledgement of we should be thinking about some of these issues for the reasons why there has historically been like, you know, from the university point of view of like mistrust or misrepresentation. And a lot of that starts with community involvement. And I feel like that has started to happen in this more cross collaboration, more like transdisciplinary research approaches, I think. So like, you know, thinking about the institution I'm at UNC, the School of Public Health, you know, with 13 different departments housed under the bigger school, I think there's more communication across areas that really think about this more like holistically or more systemically. But really it starts, I think, with thinking about how do we have most agency and what is the representation of that. And a lot of that is just representation at the core of just like, hey, it's a brown face showing up in these classes that I didn't have. And also thinking about what Indigenous-led research looks like is having Indigenous PIs to do these research efforts. And a lot of that, as we know, like it's just, I mean, I can show you slides of just how that has not changed over, you know, since the 70s. I mean, the representation of Native faculty, of Natives in academia at dean level or tenure track faculty is just has not changed, has not shifted. And so because of that, like there still needs a lot of work to be done. So starting there and then going back like that, when we think about marginalized communities, a lot of this is like underpinnings of what is marginalized and even more than that. And I want to like backtrack a little bit because I have seen newer studies and more recent papers that it was about like 1 in every 4, right? Like 70% of Native are more urban dwelling now or whatever. But I've seen those actually as lower, like maybe between the range of 50 and 70%. So it could be like half are living on Indigenous lands now versus, but I always use myself as an example, thinking like, even though I'm an enrolled member and I go home often, I'm in North Carolina for just upward mobility kind of issues. Like those things that are driving it are, you know, just anecdotally from my point of view, are thinking about going to school or having a job, and those exist in an infrastructure right now that are, for the Navajo Nation anyway, that are off tribal lands. But that's just like a caveat. Like I'm not sure what those numbers look like exactly, but to the point of saying that this is like a subgroup of a subgroup, and thinking about like urban dwelling Native issues is something that we've really focused on specifically within Native women's health, showing that we saw the higher rates of breast cancer, both like cancer specific and all cause mortality were higher in those groups. And so I think that creates, again, the point I try to drive home is in those representations, those are more likely to have a best case scenario, meaning to have more access to healthcare, like within that Kaiser study, right? That's the Bay Area, which is, you know, I don't know, like 8 million people living in that area, that it's a diverse group, but like a more or less presumed like approximate access to healthcare in that area, as opposed to the example I gave with my dad, where it's, you know, a way more remote land. And so anyway, the idea is the best case scenario is that it's creating a narrative to take back to these agencies of being, hey, these are really stark disparities that we're seeing among the best case examples of what it looks like to have reduced barriers to healthcare. And we're still seeing these crazy disparities. So the assumption is like, these could be even worse for those who don't have better access, who don't have private healthcare insurance, who have these other infrastructural communication, or other like issues. So that was kind of the like overall arching point that I try to like blast in there or whatever. Thanks.
Perfect. Thanks so much, Mark. We have about 2 to 3 minutes left before we start to wrap up here. Teresa, I want to move on to you for this anonymous question about someone wanting to increase community engagement in health disparities research, and wondering, how do you suggest getting started with relationship building, community advisory boards, and really interfacing with these communities that Mark has pointed out really have this legacy of distrust of those who have historically exploited our peoples, our lands, our resources. How do you start to kind of build those relationships?
Thanks. I don't know if I'm the best one to answer this question, but I will just say, I think it's important, as a scholar who focuses on jurisdictional and sovereignty issues, I think there's a big oversight of understanding the complexities of tribal sovereignty. And I'm saying this both as someone who's Diné and also someone who teaches students, college students, who enter, freshman year, not having any understanding that either Indigenous peoples are still alive, or having never met an Indigenous person before. So I think there's a really remedial understanding of anything having to do with Native American issues. So I feel like that's one component, right? Is like, before you can even try to enter into a community relationship, is like, do you even understand, like the history? Michael, kind of set out, the importance of like treaty relationships, and also understanding that, we have over 500 distinct Indigenous tribal nations in the United States today. And I think all of us point to that in our work, but also communicating that in a way for people to truly understand that those are, distinct nations that have distinct relationships with the federal government. And beyond that, a lot of my research also looks at the things that fall outside of these classic categories, right? So I think a lot of the burdens that at least, Diné communities face also has to do with working with state and county entities. So I think having an education and appreciation of these jurisdictional complexities, I think, is really useful. And then also, spending time getting to know people, other forms of reciprocity, and also just because a lot of, Indigenous folks, both within institutional settings and, and also in community settings, have a lot of additional burdens. So I think, the burden of responsibility is to learn what those specific burdens are, right? To undertake, a relationship. I'm not completely answering this very broad question, but I think it's more of just a burden of education.
No, it's sort of, so sorry, Michael. If you can keep it very short.
Yes, just happy to be celebrating my 71st birthday. Given the data we've reviewed, I'm just, hey, and you're going to ensure that I live another 20 years, I'm sure. I think one of the things that has not been put on the table is the fact that, and I'm going to say this in my own experience, my own lived experience, is that professionally and personally, there is still significant racism in a number of realms, in academia, in government, in public health settings.
Michael, I hate to, we will not deny that it exists, but I do want to thank our sponsors, as well as the Lancet Commission, for hosting us today. This conversation is far from over, but please be sure to join us for our next event on January 18th, in which we'll discuss drug policy and racism, and further explore these intersections as they relate to the opioid crisis and opioid policies and harm reduction. And as a correction, it's actually the 19th. So with that, thank you so much, everyone, for joining. And we look forward to joining you for the next conversation.